Hi everyone, my name is Dr. Michael Wald and welcome to this presentation which I've entitled How to Use Nutrition for a Cancer Diagnosis, and this is part one of a two-part series, so buckle up. For those of you that don't know me, I'm a doctor of chiropractic. I have a board certification in nutrition. I'm a dietitian and sports nutritionist. I have a master's degree in nutrition. I'm a life coach. I provide acupuncture to my clients, a lot of different things, and I even graduated medical school, but I do not have an active license to practice medicine. So I've been practicing for about 33 years in the holistic health field, and currently I have a practice in Westchester, New York, and Richmond, Virginia. And I've been dealing with people with various forms of cancer for all of those years. So I've learned a few things. And I'd like to concisely part some of that, or I should say impart some of that knowledge to you right now. I'm also the author of several books, including this best-selling 500-page textbook known as the Anti-Aging Encyclopedia of Tests and Natural Treatments. So let's begin with a brief disclaimer that you need to be careful with this information. It's not meant as a substitute for sound medical or health advice. It is meant simply for your education. And it's also meant to be just a little bit more than the very basics, but just enough information for you to navigate more effectively with your own cancer or perhaps that of a loved one or a friend. So let me begin by talking about some of the mechanisms that underlie most cancers. So what I'm saying here is that there are certain things that happen to more or less of an extent with cancer, regardless of the diagnosis or the type of cancer. And knowing these things will help you understand how to apply natural therapies, nutritional therapies, and even if, and also if your oncologist information makes sense or recommendations make sense to you. So number one, as a fundamental cause of many cancers, there may be a genetic underpinning. There may be a strong genetic predisposition to a cancer, or it may not be genetic, your cancer. Let's say non-Hodgkin's lymphoma. That's not thought to be genetic, but the genes underlying the cancer can be influenced by what are known as epigenetic factors like viruses. So viruses can trigger genetic mutations which can cause the cancer. So that's not directly a genetic cause. And then there are types of cancers that there are genetic causes. And then another underlying mechanism of many cancers is inflammation. Chronic, low-grade, steady inflammation, or worse, can create an environment that is simply favorable to cancer. And what about nutritional deficiencies? This is an area where medicine has really failed people with cancer. A lack of vitamins and minerals, and also macronutrition, proteins, carbohydrates, and fat can contribute to what is known as cell proliferation, or the copying of cells, which is their growth rate. So you have cancer cells, they grow, they proliferate, they proliferate, they proliferate, and then they're tumors. And then if you have certain nutritional deficiencies, you might have been able to combat that process, but if you are deficient or insufficient in certain nutrients, the proliferation process can take hold. And then there's what's known as cell-to-cell communication. A fancy term, but all it means is that cells communicate with each other through biochemical messages. Then there's immune dysregulation. Not all types of cancers involve an immune problem, but many of them do. Most people associate lack of immunity or low immunity with all cancers. It's not true, but it is mostly true. A person could have low immunity, and then there's also hyperimmunity that's not working well. That's what we call autoimmunity. We'll get more into these in a little while. And then there is what's known as proliferation and dedifferentiation. That again is proliferation is the copying of cells to proliferate them, and dedifferentiation is that these normal cells become unlike normal cells. They dedifferentiate into cancer cells. So these are underlying mechanisms that are involved in many different cancers. What are some of the limitations of hospital-based dietitian training? Before I get into this one, I need a big drink of water. As a dietitian, I can tell you that my education as a dietitian was woefully neglectful, not up to par when it comes to dealing with cancer patients. And everyone knows this that's ever been in a hospital. Everyone makes fun of hospital food. Why? It's terrible. And cancer care certain cancers require a higher level of nutrition and also nutritional supplements, which dietitians, by the way, learn really nothing about. In my entire dietitian education, I wasn't even told to tell my clients to take a multivitamin. Nothing. I just knew that there were vitamins and minerals and herbs out there, but there's no education there. And then the dietitian training is not specific for various cancers. So you have an individual that has their uniquenesses and their diagnosis and perhaps their stage of cancer and their genetics, and they may have a form of cancer that requires foods high, let's say, in proteins, or another type of cancer that might benefit from foods high in folic acid. But in hospitals, it's just not done that dietitians provide these individual types of cancer care in the form of diet. So there is a need for expertise in this area, and it's mostly in the field of the holistic practitioners in my experience, although you need to do your homework there as well. You want to make sure that you find a nutritionist that has a license to order and read laboratory work, because if you know how to read laboratory work as a nutritional practitioner with a doctorate, and by the way, dietitians and all other forms of nutritionists cannot read blood. They cannot do physical exams. They cannot do nutritional visual exams. They just can't do it. It's out of the scope of their practice, and those that are doing it illegally. So what about cancers in the United States, in terms of which ones are the ones we should be wary of in both men and women? And in men, we have prostate cancer accounting for 19% of all the cancers in men, lung cancer at 13%, colorectal cancer at 8%. And that's a good example of a cancer that has a very, very strong response to changes in nutrition, specifically removing of meat. So we know that red meat exponentially increases the rate of colon cancer in men and women. And meat is such a powerful promoter of cancer in men and women that when you remove it, you actually might improve the health outcome of that person with cancer. Now, that may not sound too extraordinary to you because, well, you may not know the following, that usually when we're talking about cancer and the role of foods and nutritional supplements to help them, it's not nearly so quick. And it's not nearly so immediate. It may take months or even years for nutrition to catch up to the cancerous process. So the sooner you start, the better. But in colon cancer, you remove the meat and there's a much better outcome. I'm not going to read all of these, but I just wanted you to know that these are the top cancers in men. And the top few cancers in women I have here. Breast cancer accounts for 30% of cancer. And we know that's another example. It's way less than 1% of cancers, breast cancer in women, is caused by genetic factors. By the BRCA gene, for example. We know that most breast cancer in women is caused by environmental influences like toxins in the air. But has your oncologist told you this? No. You might say, well, who cares? I have the cancer. What does it matter? You might be able to avoid certain environmental triggers of your cancer. And then we've got, again, lung cancer, number 2 at 13%, colorectal cancer, 8% of cancers in women, uterine cancer, 6%. So what are some of the standard medical approaches and procedures and thoughts that regular oncologists, hematologists use? Well, they do, of course, their initial diagnosis, which may be based on biopsy, or imaging, and also, of course, medical intake and physical exams. And then they have various modalities of attacking cancer. There's surgery, and if a certain amount of cancer can be removed from the body or debulked from the body, that might make that individual a better candidate for surviving chemotherapy and or radiation if that's recommended, because you've just surgically removed a lot of the cancer. And then there's a targeted therapy like laser therapy, targeted radiation, immunotherapy like the use of monoclonal antibodies. And the role of nutrition, very basic. There is really no special changes in one's diet with most cancers when people are in a hospital. And then when you meet dietitians out of the hospital, they're simply not trained. I've been studying this area for over 33 years, and I'm still learning something every day. And then we've got personalized dietary plans. They're never initiated. Never. I've never seen it. Maybe pancreatic cancer, and the gastroenterologist or the oncologist might say to the patient, eat less fatty foods and don't drink alcohol. That's about as far as it goes for the nutritional advice by dietitians. So what are some of the problems faced by cancer patients? One is lowered immunity, which will increase that person's susceptibility to infections. So many people do not die of their cancer diagnosis. They die of secondary infections and malnutrition, which is something that almost every cancer patient has. Also, there's inflammation. Inflammation exacerbates symptoms in cancer and also side effects. So natural ways of managing inflammation, of course, make sense. And then there's infection risk. There's a higher incidence of infection risks in persons with cancer with lower immunity. And by the way, chemotherapy is usually started, and then an oncologist will notice on the blood test that the white blood cell count is going down, too low. So what do? They stop the chemotherapy and or radiation at the time. They stop all the cancer care, and they give the person a drug called leucovorin. Do you know what leucovorin is? It's high-dose folic acid. That is the go-to for oncologists, hematologists. Now, if you ask them, what is leucovorin made of, they will not be able to tell you. Then if you ask them, do you believe that nutrition, like the use of high-dose folic acid, might help some cancer patients? They will say no. What can I tell you? It's a lack of education mostly. It's a lack of interest and also conscientiousness on the part of the doctors. And also patients aren't demanding it. Then there is malnutrition and malabsorption. There is plenty of evidence that suggests that many cancers happen and or may have worse outcomes in those with poor nutrition or those that have malabsorption. And if you're malabsorbing something, you will be malnourished, that is. So lowered immunity, inflammation, increased infection risk, malnutrition, malabsorption are things seen in almost every cancer in men and women, and all of these can be managed nutritionally. Am I saying that nutrition is the only thing that a person needs to beat their cancer diagnosis? I'm not saying that. I am saying at the very minimum that nutrition is foundational and must be done and has been proven again and again through thousands of studies. You can find them on medical databases like the Cochrane database and PubMed.com, the National Library of Medicine database. Now, this is a concept you probably have not heard about before, and it's called nutritional synergism. Now, you may have heard of synergism where things work together well, but nutritional synergism when it comes to cancer is particularly important. So let's say, for example, you read a study and it says that high doses of vitamin C in the 30 to 50,000 milligram range, or the 30 to 50 gram range, is the anti-cancer dose that will kill some cancer cells. It will not be possible for you to consume 30 to 50 grams of vitamin C in a day. It is physically impossible. You will throw it up. You will be sick to your stomach. You can't do it. So how do we make vitamin C work well at a much lower dose? Well, that's where nutritional synergism comes in. And I'm paraphrasing this slide right here with what I'm telling you. So basically, if you want to, let's take that vitamin C example. Let's bring it down to an easier number, 10 grams, okay? That's 10,000 milligrams. You have 10 grams of vitamin C. Still, an amount that would make you sick. It's not possible for most people to every day take 10 grams of vitamin C. So if you want to reduce that 10 grams to 1 gram, which is an easily manageable dose, you would have to nutritionally balance that vitamin C with at least 10, because we bring it down 10 orders of magnitude. You'll have to add to that vitamin C of 10 grams, and you want to bring it down to 1 gram. You have to combine it with at least 10 other nutritional synergists. Maybe it's astragalus, maybe it's boswellia or resveratrol, and those ratios have to be right. So what I'm basically saying here is, if you want the anti-cancer effects of very high doses, which are impossible to take unless you get them intravenously, and you want to reduce this multiple times, you have to add other synergists. So you'll have more supplements, but much, much lower supplements. And guess what? They will act as if they are higher doses. This is a concept that you might want to rewind a few times. Many of my very intelligent patients need to hear this a few times. But if you think that there is one magic nutritional anti-cancer supplement, it's just not going to happen. A person with cancer is going to need dozens and dozens of different nutritional supplements. Always minimizing them, of course, but they have to be balanced properly in a synergistic way so the doses are low, but the combinations are such that they act as if they are higher doses, so it can improve the person's ability to manage the cancer. So maybe take a screenshot of this, listen to that one a few times. Next, this is another concept that, unless you've been listening to my podcast, you almost certainly have not heard about. So my book, which I showed earlier, this one right here, the Anti-Aging Encyclopedia of Tests and Natural Treatments, reviews, it took me years to write this, reviews what are known as healthy ranges on tests, such as blood tests, versus clinical ranges. Now, you all know the clinical ranges, even if you don't know that you do. Those are the ranges on a blood test that your doctor has looked at and said, look, your cholesterol is this number compared to that clinical range. You are high or you are low. So, for example, with cholesterol, we have a range of somewhere between 100 and 200. So if you're 150 or you're 199, your doctor would look at you straight in the face and say, oh, your cholesterol's fine, without saying to you, well, if you're 199, we want to get you in a different, healthier spot in the range, which is associated with a much lower risk of cardiovascular events. So 165 is far fewer cardiovascular events than 199, but both are normal. Look at these examples here. I'm just going to go over maybe two of them. Let's use vitamin D because that's a very popular one. So a healthy range, based on studies of healthy people, say that 65 to 70 nanograms per milliliter is the best place to be with your vitamin D3 level on a blood test. Your doctors use 30 to 100, very, very wide. So the 65 to 70 is a tighter place within that 30 to 100. And when you are at least a 65 or up into a 70 or even higher in the normal range, the higher normal your vitamin D, the lower your risk of dying of anything. And there's a better outcome in most cancers too, the higher normal the vitamin D. So having a normal test in the, as you can see, it says the clinical ranges. These ranges are either, you see where I put in the brackets, the first one, vitamin D, that's just too low, that range. The hemoglobin, which has to do with oxygenation, the clinical range is much too low. And the albumin is also too low. And the C-reactive protein is too high. And the vitamin B12 is too low. Those clinical ranges are based on seemingly well people who donate blood. They can walk in there with a brain tumor, you wouldn't know it. No one's testing for it. No one's looking for their hepatitis or something else. And then you're compared to them, and the ranges are going to show that. But when Cornell, for example, and other gerontology, healthy aging researchers have looked at the healthy ranges, they're much closer to the ones that I have right here. So when I interpret a person's laboratory test, whether they are someone with cancer or they want to prevent cancer, I'm always comparing them to both the clinical range and also to the healthy range. So this will do it for part one of cancer and nutrition. And I've summarized on this slide for you also that I give people nutritional supplements, for example, that are not based on just the recommended daily allowances. The RDAs, in case you haven't heard of those are governmental guidelines of the minimum amount of a supplement to prevent you from dying. In other words, the minimal amount of a supplement to prevent a deficiency disease. The healthy blood levels, or what we call the orthomolecular doses of nutrition, are much, much higher when you want to maintain health, or you're an athlete, or you have a cancerous process. So more may be better of certain things. And then I mentioned the clinical versus healthy ranges. We just talked about that. We always have to consider the medications involved in the person's whole cancer situation. Okay, so I will see you at part two, and make sure to be there. Thank you. Hello again, everyone. This is part two of how to use nutrition for cancer diagnosis. So I've been practicing for over 33 years. I'm a doctor of chiropractic. I went to medical school, although I do not have an active license to practice medicine. I'm a board certified nutritionist. I have a master's degree in nutrition. I have a PhD in holistic philosophy. I'm trained in acupuncture. I'm a life coach. And throughout all of these years and dealing with those with cancer, I found that usually a combination of things tends to be better. But today, we're going to focus on nutrition. If you haven't listened to part one of this talk, please do that. So let's begin with a disclaimer that this information is for your education. It's not meant as a substitute for sound medical or health advice. I would not advise a person with cancer to try to figure out their own cancer with AI or Google or what have you. I see these people all the time. They make grave errors. So please get the appropriate help. At the very minimum, which I mentioned in the other presentation, you want to find a doctorate or a person who has a degree, a health degree that allows them to order and interpret laboratory tests. Dietitians cannot do that. Clinical nutritionists cannot do that. Most naturopaths cannot do that. Most herbologists cannot do that. Now, some of them are doing it, but they're doing it illegally because these laboratory companies will peddle to them because they want to make money. So you need to know who you're seeing, and you need to make sure that they have the right qualifications for your particular health needs. So the information here is for your education. It is not meant as a substitute for sound medical or health advice. So this is an important part of information in terms of cancer care. The importance of nutrition and the varying needs of nutrition from person to person and also in a given individual over the course of time. So according to the World Health Organization, nutritional deficiencies or nutritional influences account for 60% of men's cancers and 40% of women's cancers. So if 60 and 40% of cancers have a strong association with cancer, why isn't advanced nutritional care part of oncology and hematology cancer workups in the United States and elsewhere? They do not learn it. That is it. The average physician has 23 hours of nutrition education in an average of 7 years of medical training. And those that do have nutrition training, it's very, very basic. So of course, if you ask them, could nutrition make a difference in my health? They're mostly going to say no. Others that are a little smarter will say, well, nutrition is pretty fundamental. Just eat a balanced diet. Yeah. Just eat a balanced diet. What does that even mean when you have cancer? It is a meaningless statement. And we know also that nutrition improves overall nutritional status, which has a better outcome in cancer care. If someone is better nourished, they will, generally speaking, have a greater ability to mount a strong immune response against cancer cells. If they have strong nutrition, they will have a reduced risk of infections. And everyone, it's malnutrition and infection that causes the deaths of most people. It's not their cancer. It's the secondary side effects, malnutrition and infection. Also, as I mentioned, nutrition will reduce side effects of many different types of chemotherapy and also radiation. You might find that your doctors prefer that you do not begin any nutritional supplements or special diets if they're giving you some radiation and or chemotherapy, and then you need to ask them why. Usually when you ask them why, they will get very upset with you because they don't have a reason. They've just been taught that. And I get it. They've been taught that because they're not taught nutrition. So their go-to statement is don't do it. Yes, but how about why? Why shouldn't we? And then a conscientious practitioner would look into this and quickly discover that they have been wrong, that the proper nutrition for an individual can improve the effects of radiation and cancer care while reducing many of the side effects, which means the person will be able to have their cancer care too, along with their nutrition. But it has to be based on their needs, and the nutrition needs to be prescribed by a highly qualified person in this area. We know that improved nutrition enhances and improves the rate and extent of healing. People recover faster, generally speaking, more fully. We mentioned immune function a few different times. And this other one, the third one, preserving lean mass, is particularly important. So when it comes to lean mass, what are we talking about? We're talking about muscle on the body and organs. So those are lean mass. Now think of an older person growing old, and maybe a person growing old with disease. Now, when a person is growing old, they atrophy, they shrink, their lean mass shrinks. And since their lean mass includes their organs, which produce all of the lab results you see on a piece of paper, you're going to get worse lab findings when someone is losing lean mass. Lean mass is the single best predictor of morbidity and mortality in human beings. What does that mean? That as you are losing lean mass, it doesn't matter if you're using nutrition, you're doing yoga, Pilates, meditation, fasting, intermittent fasting, if those methods do not improve your lean mass, you are not likely living longer and or with a higher quality of life. What you're doing, whatever that is, must increase your lean mass to be real. Even if your cancer doctor says, well, your cancer markers are coming down, your tumors are shrinking, but if the lean mass is getting worse, those are just temporary findings. There's very little correlation, by the way, with dropped cancer markers and survival, because they're going to be dropped when you receive radiation or chemo, and when you stop, they go up. Everyone's all surprised. They shouldn't be. And then there is nutrition, which supports detoxification of chemotherapy drugs. You need a healthy liver, you need a healthy kidney, you need a healthy gastrointestinal tract and other organs to properly manage a lot of these drugs. So of course you're going to want to use the properly balanced nutrition so that you can walk into your cancer care much more fortified, nutritionally speaking. Sadly, I have some people who are very, very smart people, but they've been scared to death by their oncologists, hematologists into not changing their diets and certainly not taking nutritional supplements. And many of these people over the years have died, because they just were programmed or they simply felt threatened by their doctors or confused. And because of that confusion, it made them not be able to make an educated choice to include nutrition. Also, we have nutrition, which if it's optimized for the person, maybe it's more protein in this person, maybe it's higher levels of antioxidants, detoxifying agents like glutathione, N-acetylcysteine, glycine, vitamin C, whatever it may be, resveratrol, vitamin D, the list goes on, we can reduce inflammation by helping to minimize the inflammatory process in cancer. Side effects are usually reduced. Improved microbiome health. Nutrition will keep your gut healthy, and guess what? 70 to 80% of your immune system is in the wall of your small intestine. And then you have another percentage of it in your bone marrow. And then you have another percentage of it in your liver, in the Kupffer cells or the Kupffer cells. And then finally, the proper nutrition can help regulate blood sugar levels, because as many of you know, high blood sugar is a fuel for cancer cells, just like low blood pH is fuel for cancer cells, just like low oxygen concentration, fuel for cancer cells. Also, with proper nutrition, we reduce the risk of secondary cancers and recurrence from the cancer you have. Many of my clients have no idea that the toxic chemotherapy that they're receiving or radiation increases their risk of other cancers in the future. I'm not saying this to try to convince you never to have the standard of care. In fact, I believe in the standard of care in medicine. I just don't believe in using it alone. But if we're going to choose that, we want to make sure that our nutrition is as well put together as possible so we can offset that malnutrition, offset inflammation, and keep the immune system in good shape. We also want to use nutrition to maintain our bone health, because cancer can just run through soft bone. Proper nutrition can help maintain emotional and cognitive health. Many people who receive chemotherapy and radiation or have had a cancer process for quite a while, even short periods of time though, complain of brain fog and fatigue, things that regular medicine doesn't really seem to have any answers for, but nutrition does. Also, nutrition can help improve sleep quality. And proper sleep is one of the best predictors of disease risk across the board. So if you're sleeping better, you're probably healing better. So we want to support one's personalized nutrition and metabolic needs by looking at their actual chemistries, their genetics, their unique situation, their laboratory work, their likes and dislikes of different foods, and genetic markers. All of these things need to be considered when trying to determine the best possible nutrition for an individual, and change that nutrition over time as the person's response happens, and or maybe they have poor compliance with some things. So it's never just, here's the plan, see you. You have to understand that cancer is a serious process. It deserves a serious nutritional approach. I've had people come to see me. They thought they were going to have 1 or 2 conversations with me and they would be done. That's not how it works. You're going to need a half a dozen to a dozen consultations and or treatments of varying sorts over many, many, many months. And of course, that's individually determined. So that will about do it with this additional amount of information. This is part 2 of Nutrition and Cancer. Please make sure to listen to part 1. Keep in mind that we don't want to give people just the RDAs, the recommended daily allowances of nutrition. We want to give them orthomolecular doses, which are larger doses, which can have anti-cancer effects. We want to look at a person's laboratory work. We want to compare that laboratory work to healthy people, not just average people. If I compare you to healthy people, yes, you're going to have more abnormalities, but that is a better goal to shoot for. That's it for today. Thanks for joining me, and I'll see you at the next podcast.